Good morning. This is a part of my talk which I had given to Karnataka Orthopedic Association for OASIS Instructive Course lecture series as a part of tuberculosis spine, laboratory diagnosis of TB spine, making sense of blood test and biopsy. So I have no conflict of interest relevant to this talk. What are the learning objectives of the present talk? To know about various laboratory investigations regarding TB diagnosis and management, to know how to do biopsy in a pod solution, to know what is the relevance of drug-resistant TB and various tests used for diagnosis, masqueraders of TB and other diagnostic dilemmas, special situations like TB in pregnancy and HIV with TB. So in 2014, WHO came out with End TB strategy. That meant they wanted to reduce 90% of deaths by 2030. This has three pillars and four principles. Pillar number one is integrated patient care and prevention, which includes early diagnosis and drug sensitivity testing, treatment prevention, and collaborative TB and HIV treatment. Other two pillars are more relevant for preventive medicine. So diagnosis of spinal TB includes radiological tests, laboratory tests, and biopsy. Radiological tests includes plain radiographs, computed tomography scans, MRI, radionuclide bone scans, and FDG PET scans. Laboratory tests includes CBP, ESR, that is complete blood picture, erythrocyte segmentation rate, C-reactive protein, liver and kidney function test, IgM, IgG to Mycobacterium tuberculosis, interferon gamma release assays, MON2 and tuberculin skin test. Biopsy includes open or percutaneous. Open is nowadays done as a second procedure in case the percutaneous biopsy fails. Percutaneous biopsy can be usually the fluoroscopy guided. Ultrasound or MRI guided is used in special situations like TB, spine, pregnancy, etc. CT guided can be done on a day care basis by interventional radiologists. Based on sample that is obtained, it can be FNEC or core biopsy. So imaging in spinal tuberculosis includes imaging in active disease, diagnostic and therapeutic imaging, follow-up imaging to assess response to treatment. A point to note here is that plain radiographs are usually normal in early disease, and it takes at least 2 to 5 months for the disease to be detected on plain radiographs, because at least 30 to 40% of demineralization has to occur for something to be detected on radiograph. Thus, the importance of MRI in endemic countries like India. So radiological involvement in TB spine, this is known to everyone, but still for completion's sake, I'll tell. Paradiscal, as we know, disc and the intervening bodies are embryologically from the same unit, so it is the most common involvement. So it can be seen as a paravertebral shadow more than 5 mm above the cricoid cartilage, more than 15 mm below that level. In thoracic spine, look for a bird nest abscess. There can be sometimes the abscess can expand and lead to aneurysmal phenomena and can erode the body, leading to sawtooth appearance. Anterior disease TB is essentially an anterior disease, so it can be restricted to vertebral body alone, and it is restricted by anterior and posterior longitudinal ligaments. There can be multiple contiguous vertebra involvement as well. Central TB, also known as vertebra plana, is very rare and commonly forms a differential diagnosis in children, where eosinophilic granuloma can also be a cause of it. Neural arch or appendiceal TB is much more rare, less than 5%, and can involve the posterior element. Sometimes there can be unusual presentations like psoas abscess or sinuses, where involvement of bone is much less and there can be a profuse abscess. So to summarize, as I told, paradiscal, central, anterior and posterior. Skip lesion can be seen if the infection spreads along the beds and plexus of vein. Synovial involvement is seen in CVJ tuberculosis, and it can involve the synovial membrane of atlantoaxial and atlanto-occipital joint. has decreased. So blood investigation, ESR, very commonly done. More than 20 mm per hour has been noted in 60 to 83% cases, helps in monitoring of the disease. A decreasing trend means it is responding to ATT. If it is persistently elevated, that means there is a poor response to therapy, there is no compliance, or there is drug resistance, or we are dealing with something else. CRP, it's an acute phase reactant elevated in 75% of cases. CBC, lymphocytosis is seen, but there's a new marker called lymphocyte by monocyte ratio, which is seen in osteoarticular tuberculosis of children. So it is helpful to monitor response. Antibodies to Mycobacterium tuberculosis seen after 3 months has not much of a clinical significance. Thus in 2011, WHO has told it should not be used to diagnose active TB. So to summarize, laboratory diagnosis of tuberculosis includes direct methods, indirect methods, newer and experimental methods. Direct methods detects actively growing bacilli via microscopy, culture, antigen detection, or nucleic acid detection. Indirect methods detect the immune response against bacilli by measuring antibodies as in IgRA or tuberculin skin testing. Newer and experimental methods which are not much of clinical relevance but can become of relevance in future include whole genomic sequence, LAM assay, Gene Expert Ultra, CTB, and some serum biomarkers. So ELISA based test, this is this IgRA, interferon gamma release assay. As you can see, there is an antigen called ESAT6 or CFP. So T lymphocyte release this IFN gamma like antigens, IFN gamma against antigens like ESAT6 and CFP. ESAT6 is a secretory antigenic target. CFP is also a surface protein which can act as stimulant. So this commercially available test called QFTG or T-spot TB assays. So a point to keep in mind is they are used to only diagnose the latent infection. To diagnose an active infection, clinical history, imaging, and biopsy is necessary. So tissue is indeed the issue, and which is the part of biopsy. So how do you biopsy a lesion in lumbar spine? You go by a transpedicular approach or an extrapedicular approach, and you read the lesion. For dorsal spine, lower dorsal spine, you can go by a transpedicular approach. For upper dorsal spine, where the pedicles can be narrow, you can go for an extrapedicular approach, either by a superior costo-transverse approach or by an inferior costo-transverse approach. So cervical spine, you can give a small nick, and via the Smith-Robinson approach with finger dissection, you can vee away the carotid and other vascular structure and reach the paravertebral abscess or the body of the cervical spine. Or if the abscess and the lesion is posterior, you can go via posterolateral approach. CVJ, you can do a transoral biopsy. So this is the data classification which tells what is the treatment that has to be followed. Type 1A usually has isolated bony involvement with a mild abscess. So this can be done, the diagnosis can be done on an OP basis and ATT can be followed. But if the abscess is large and if the bone destruction is quite a lot, then you have to go for surgery with abscess drainage and debridement, which forms the type 1B, type 2 and type 3. Type 3 also has some deformity. So it may need anterior and posterior correction as well with deformity correction. So though this procedure appears simple, it can be fraught with complications like pneumothorax, spinal cord or vascular injury or injury to other important structures which are nearby, and it is absolutely contraindicated if the platelet count is less than 50 and if there is uncorrected bleeding in the abscesses. So some technical tips on biopsy: do it under GA or local with or without sedation with the presence of anesthetist. Localize the lesion before you put your needle by the use of MRI, X-ray and other radiological investigation. In multiple lesions, target the largest and the most superficial preferred. Usually we use 11 gauge J needle. There can be other needles that can be used like Ackerman, but I don't have any personal experience with that. Target 2 o'clock to 3 o'clock for your right pedicle and 9 o'clock to 10 o'clock for your left pedicle. Lytic more than sclerotic, core more than FNAC, granulation tissue more than pus and cervical, and lumbar more than thoracic. These are the pointers for the best results. This can also be biopsied either by starting from a lower part of the pedicle, like 4 o'clock or 5 o'clock for the right side, and then changing the trajectory along to reach the disc. Or you can use this method described by Dr. Basu by using a kyphoplastic cannula. So once you have the biopsy in hand, you have to send some of it in saline, some of it in formalin. The one in formalin, you send it for histopathology. And the one in saline, you send it for staining like AFB, ZN, culture, gene expert, line probe assay, bacterial and fungal culture. Microscopy, at least 10,000 bacilli has to be there in order to detect in AFB staining. So it can be detected by light microscopy, fluorescence or light emitting diodes can be used. WHO recommends LED over conventional method. Culture, there can be egg-based media, Lowenstein Jensen LG media stone brick, which takes at least 2 to 4 weeks. ALC, automated liquid culture, which is 20 times more sensitive and takes only about 2 weeks, includes Bactec 460 TB and Bactec MGIT 960. Bactec 460 TB used to be radioactive and labor intensive, whereas 960 uses a ruthenium pentahydrate oxygen sensor, which is non-invasive and non-radiometric. So WHO at present recommends the use of both. Antigen detection, there's only one place in TB diagnosis where antigen detection has a role. It is in TB with HIV. So there is this antigen called lipoarabinomannan, which is a glycolipid formed on Mycobacterial species. So this is an ELISA or dipstick test, which has a turnaround time of 4 to 6 hours or 20 minutes. And lateral flow LAM is used for the diagnosis of TB with HIV. Nucleic acid amplification test, it is a completely different way to diagnose TB. Instead of using an antigen or antibody, we use the nuclear material of Mycobacterium DNA to diagnose TB. So even a small sample can be used to diagnose by amplifying it and recognizing it. So it has much better sensitivity and specificity in the diagnosis of TB, and it can lead to an early diagnosis instead of waiting for 3 to 6 weeks or months for an immune response to happen and then the diagnosis of TB. So currently we have cartridge-based nucleic acid amplification tests, line probe assays, loop-mediated isothermal amplification and genomic sequence. The WHO approves the first 2 tests. CBNAT, which is commonly called Gene Expert, it's a real-time PCR for simultaneous detection of TB bacilli and RCOV gene, which is used for rifampicin resistance. Sensitivity and specificity around 95% and up to 1114 CFU per ml. Compare this to 10,000 for AFB. So turnaround time is 1 to 2 hours, at least 5 ml of blood is required. It also helps in differentiating Mycobacterium tuberculosis with non-tuberculous Mycobacteria. A newer generation called Gene Expert Ultra, which detects 16 CFU compared to 114 of Gene Expert alone, but it can be helpful in smear negative and HIV patients. So this present instrument which you see is a 6-color optic. A newer one is a 10-color optic, which can help in detection of MDR and XDR TB. This is what is called Expert MDP XDR test. But this is not widely available as of now. Loop-mediated isothermal amplification, it uses a different method here. So instead of changing the temperature, it relies on a thermocycler, which would bring about the whole process of amplification at one temperature. Hence it is called isothermal. So this can be read by a naked eye or a fluorescent dye. It requires less than 2 hours and is useful in resource-limited environment like UHCs and THCs. So a single study evaluating the LAMP assay has found 90% sensitivity for recognizing 2 genes of osteoarticular tuberculosis. TrueNat MTB, this is only used in pulmonary TB. It's a make in India product. Extra-pulmonary, it has not been studied till now, so we await the result of that. So if the TB is progressing despite ATT, suspect drug-resistant TB. These are the truly criteria saying that no signs of progressive healing, increased destruction, new foci, and increase in size of abscess. So we know the classification of drug-resistant TB. Either it can be RR-TB or HR-TB. MDR is where rifampicin and isoniazid both are involved. Pre-XDR is MDR plus fluoroquinolone, and XDR is extensively resistant TB is MDR plus fluoroquinolones plus injectable agents. TDR, though not recognized by WHO, means resistance to all the drugs. So how do you diagnose MDR or XDR TB? At this point, you should involve pulmonologist or an infectious disease specialist. So it can be diagnosed by phenotypic or molecular method. Phenotypic includes culture-based or liquid-based methods. Culture-based, proportion-based method is the most common one, though there are other methods like resistance ratio and absolute concentration. Liquid-based, which we have already discussed, BACTEC, FOL60 and MGIT. Usual cases of TB takes 2 weeks, but in MDR TB, the liquid-based culture takes about 7 to 8 weeks. Probe-based assays includes line probe and gene expert, which I discussed just now. And next, sequence-based is sequencing the whole genome of Mycobacterium tuberculosis via next-generation sequencing or whole genome sequencing. Universal testing for drug-resistant TB is the need of the time, and we do it via gene expert. So line probe assay, it is a family of DNA strip-based tests which can detect MTB DNA by using something called amplicons, which are DNA amplification products. Line probe assay are technically more complex, but they can detect resistance to a different first line and second line agents, and the results can be obtained in 5 hours. It is WHO recommended for MDR and XDR TB. First line line probe assay for isoniazid and rifampicin, and second line for the second line agents. So can helpful in detecting MDR TB. Histopathological examination, as we are told, a part of sample is sent in formalin for histopathological examination, which can be processed, which I just mentioned. So we can detect caseating necrosis, epithelioid cell granuloma, lymphocytic infiltration, and Langerhans giant cells. So it can be positive in 50 to 70% of cases, but caseating granuloma is not the pathognomic of TB. It can be seen in other conditions, which I will show just now. So as we know, TB is a great mimic and other pathologies can masquerade as TB. So we know the clinical mimic, brucellosis, Anderson lesion of Angst-Pond, and sarcoidosis are very, their clinical presentation matches very close to that of TB. So finally, TB in pregnancy, try to avoid biopsy and diagnose only on the basis of MRI. All the first line agents are safe without any fetal malformation. If at all you have to operate, try not using fluoroscopy. Try something like an AP decompression with Hartshell rectangles. And to summarize, this is the latest review article from Ganga Hospital, Coimbatore. So I have covered all of this except for some serological tests like fibrinogen, alpha-2 microglobulin, CRP, and MMP9. These are still in pipeline and not much used clinically. So these are my additional readings.